Welcome back to Medical Associates Health Check. Today's episode is going to be focused on a topic that we don't really talk about, but it is still important and relevant from a medical perspective, and that is cosmetic breast surgery. And I have back, by popular demand,
Thank you.
Dr. Liron Olivier. How are you doing?
I'm good.
Okay, so why don't we talk about what breast surgery is from a cosmetic point of view, because it's increasing all around the world. So the floor is yours.
Yeah, so I mean, it begins with what the patient client sees, what's their ideal image of themselves.
Yeah.
And that's trying to achieve that image for that patient. But again, we always have to put a fork into ideally what you want to achieve and what is achievable.
Correct.
So it's really trying to understand what the patient goals are in terms of the size, the shape, and symmetry of the breast. And then also it's also a big building block on what your body structure is.
Yeah.
So you need to know what your goals are and how we're going to achieve it, and if it's possible to get that ideal vision and what you are for yourself.
I think that's really difficult. I shouldn't say it's difficult. What it is, it requires the doctor or the surgeon to really listen to what the patient wants and explain to them, well, based on what you're asking for, these are the options available to you. And getting them to understand what is available versus what they have in their mind is the biggest challenge.
Yeah. So a lot of patients will come wanting that breast augmentation. So breast augmentation can be achieved by mainly two main modalities, where we can use an implant, or there's the new trend of more using fat grafting.
Yeah.
So that's the debate. A lot of patients will come and doctor, I want you to take some fat from this breast and put in this breast, or take some fat from this side and recreate that breast with fat from the sides as well.
Yeah, I think fat grafting is becoming more and more popular, especially with other types of procedures. But I think the common one you probably see is taking the fat from the abdomen and moving it up to the breast. Is that right?
Yeah, I mean, that's more of a reconstructive element, but in terms of creating that a more increased breast volume, you could use elements of actually aspirating that fat, harvesting that fat, and injecting it into the breast parenchyma to give you a more fuller and an increased volume in the breast.
But if I wasn't mistaken, we were talking about it just a little while ago, that it's not as easy as everyone thinks. You can't just cut off a piece of fat and put it in the breast.
Yeah, so it really has, you have to harvest it and you have to inject it into an area where there's a good blood supply.
Right.
And you can't inject a certain quantity. You know, there's a certain limit at which you can inject at a particular time. Because if you overfill with too much breast tissue, too much fatty tissue, that fatty tissue will die.
Yes.
So when we infiltrate, let's say we infiltrate a certain volume of breast or fatty tissue into the breast, only about 60 to 70% may actually survive. And then sometimes when you infiltrate that fat into the breast, you could also get some of that fat dying, which can cause some fat necrosis, and sometimes that even some sort of a lumpy feel to the breast as well.
I was just about to say that changing your breast to a smooth texture to more of a contoured or lumpy texture.
But I mean, with improved technology and skill set, it could be achieved. But again, sometimes you need more than one instances or one-on-one visit to the surgical theater to actually have that, achieve that goal and volume you want. But the one with the breast implant obviously is more common because it's fixed. We know it's a fixed volume, it's a fixed size and shape, and we can particularly pick that implant that suits that patient.
This might be a little controversial, but there are countries that allow young people in their teenage years to have breast implants. What are your thoughts on that? Is there an ideal age?
I think legally in Trinidad it's probably going to be at the age 18. I don't know exactly. But I think it depends on the patient and obviously their parents to determine if the patient is mature enough to determine if they should have that augmentation. But also from a medical standpoint, the breast tissue is still developing.
Correct.
So there must be some limit to the point of where you don't know what's the outcome of the breast tissue is going to be before you deem to put a foreign body into it. So I think 18 is probably a fair age to make a decision, at least probably the lowest age from a legal point. But I think the breast is still going to be evolving at that age.
Now, one of the more interesting things that we see is the use of artificial intelligence in medicine. We talked about it last time. So where do you see the future of cosmetic breast surgery?
I think it's already been used, is actually predicting your outcome with the cosmetic surgery. And so you can manipulate the size of the implant, manipulate the outcome, and see if that's what you actually want of yourself. You know, sometimes you do an operation, a patient is, I didn't really like the size. I want it to be smaller, I want it to be bigger. I think AI is going to allow us to more predict that outcome at a greater instance.
So basically, we're going to have a designer body available.
Well, it depends on what you deem as designer.
So how does one go about this? They come into the hospital, they say they want to see you in clinic. And what is your step-by-step process for them?
So one, again, it's always about getting the goal. What you want to achieve, what size breast you want to achieve, what volume you want to achieve. Some patients will walk with an image of themselves, what they want to see themselves, or most of the times will be an image of themselves when they were younger and they want to have a bigger volume. But my responsibility is to get that goal and then to assess the patient's chest wall. So you have one to assess the breast itself and then the underlying chest wall. Because the width of your chest wall is important to determine the width of the implant. Sometimes patients have chest walls that push forward, and sometimes patients have chest walls that goes inwards. We have special medical terminologies for that. And that itself, could actually influence your breast implant and breast augmentation.
You see, I don't think many people know about this, so it's really, really important that we talk about it.
Yeah, and then you determine the size of implant, because a lot of women sometimes, if they're coming for breast augmentation, they want to have a large volume. Sometimes a large volume might not suit your chest. It may come out too much on the side, which can cause shifting of the implant, and you can get that increased displacement medially, which can look a bit awful as well. So it really has to be predetermined an exact size for you, what we can achieve with you. So that's the breast and the size, but then also sometimes we have to assess the level of ptosis. And what level of ptosis is where the nipple is in the breast. So if the nipple, as you get a bit more mature, your nipple tends to go point downwards a bit more, and that's called ptosis. So ideally, your nipple should be above what we say the inframammary line. That's where the breast meets the chest wall. Your nipple should be above that. And then you have variant degrees of ptosis, where it actually will start to go 1 centimeter below that, and then a couple more centimeters down until the nipple is actually the most dependent part of the breast pointing downwards.
Right. So and that's what most women don't want to see and then opt for their surgery.
So that helps us to determine what the treatment is. So sometimes you may feel if you're coming for augmentation, is just to put an implant in. The envelope, the skin, the breast tissue determines what approach we do. So sometimes I have to move the nipple, because if you put an implant on your chest and the implant is the most prominent area and your nipple is pointing downwards, it's not going to look cosmetically pleasing. So you now have to fill that you have to reconstruct that skin envelope to rest on the most prominent part of the breast. And that's where you talk about a mammoplasty with augmentation.
Well, just hold that thought, because we're just about to go to break. And when we come back, we'll be talking about the different surgical types. Stay tuned.
Medical Associates Hospital is the most affordable MRI imaging center in Trinidad and Tobago. Patients have quick access to bookings and service, on-time appointments, high-quality, convenient, and fast scans. With $800 off all MRI scans, we guarantee we have the most affordable MRI service in Trinidad and Tobago. Medical Associates Hospital, #1 healthcare for the entire family.
Good day, my name is Dr. Laurent Olivier. I'm a breast surgical oncologist. Today we're going to talk about the breast mammogram machine. This is a tool that we utilize for breast cancer screening. It's the only recommended tool for breast cancer screening, which is actually what we call a 3D mammogram machine. Allows us the ability to take views of the breast at various angles, as you can see where the machine is moving left or right, and allows the computer to reconfigure a picture, a 3D picture of the breast. This allows us to pick up 25% more breast cancers and allows the false positive rate to be reduced by 15%. What that means, the ability to pick up abnormality is actually more accurate than the previous mammogram machines. This machine is readily available at Medical Associates, and the standard of care, which is mammogram machines for screening, is now starts at the age of 40. With the 3D mammogram, it allows us the ability to pick that abnormality and diagnose patients for breast cancer.
Medical Associates Hospital is the only internationally accredited tertiary healthcare institution in the Caribbean for quality in medical care. Medical Associates' gold standard for quality medical treatment, culture of safety for patients and visitors, care based on leading, evidence-based best practices and compliance with international standards make us the leader in private hospital care in the Caribbean. Medical Associates Hospital, #1 healthcare for the entire family.
Welcome back. Before the break, we were discussing what the patient needs in cosmetic breast surgery and what the expectations should be. Now we're going to talk about the different types of surgery. So, Liran, let's dive into it.
Right. So, again, the main element in augmentation is placement of the implant.
Right.
You could have two types of implant. You could have a silicone base or you could have a saline. We tend to move more now to the silicone based implants.
Because the saline has a lot of risks and complications from
the risk of the saline really is that if it leaks, the body will absorb it, so you'll have a significant reduction in size.
Right.
Versus the silicone, if there's a rupture, the silicone actually is very gel, so it stays into place. So, and it feels more comparable to breast tissue.
Okay.
Yeah. So the implant can be placed, again, besides picking which type of implant, and we tend to use more silicone, the implant can be placed under the muscle, which is called subpectoral, under the muscle, or above the muscle. Those are the two main elements. One of the bigger and the new approaches that we do now is actually putting under the muscle. And previously, in the past, you would have seen that implants tend to look a bit higher than normal. Now we try to get that sort of drooping, natural ptotic sort of breast. And that's achieved by actually cutting that pectoralis muscle and getting that breast tissue to cover the implant. And that gives you that more of a natural look and appearance to the breast.
Screening with women who have implants in, is it possible to screen them? Is there a limitation?
I think it's an important topic because a lot of women who have breast augmentation have the feeling that they can't have a mammogram.
Right.
And there are certain techniques what they can do is actually, it's called breast displacement. So they actually squeeze the breast and push the implant posteriorly.
Okay.
So when they take the image, they
when
could
you say
actually
posteriorly, you mean
push it backwards towards more deeper into the chest.
Yeah.
So the breast tissue could be more anterior, more forward, and then they take image of the breast tissue. So it is something that is they can perform.
So I think the fear is that if you squeeze, because the mammogram will squeeze, that it will damage the implant in some way. But
no, the implants can be displaced. It's just really displacing the implants, not really squeezing them.
Yeah.
But it's important because the number of breast augmentation obviously is increasing. So it means we still want to maintain that ability to screen patients.
So what I want to focus on is there are medical reasons as to why we do certain types of cosmetic breast procedures. So in particular, breast reduction. And it's not talked about enough, but it is commonly seen. We do see it even in medical associates. So that's the back pain that women get, shoulder pain. What are the other reasons that women have come to you for breast reduction?
So breast reduction surgery, I mean, I don't even think it's cosmetic. I mean, the outcome gives a nice cosmetic outcome because you get that breast with the nipple being in an ideal position above the inframammary fold. And some women are very happy because they feel the sense that, one, they can actually get a bra to fit. Because if you know any patient that has significant breast tissue, they have to get a bra out of the country.
Correct.
And it's significantly costly. Actually, recently I did a reduction on the patient. The first thing was like I could actually buy a bra in PriceMart. I don't have to go away to get a bra. And then sometimes they don't even require a bra afterwards. But definitely, I don't see it as cosmetic. I actually see it as non-cosmetic because I think it's a medical reason. Patients have shoulder notching where the bra actually cuts onto the shoulder and there's indentation. They get back pain, neck pain. They have exhausted at the end of the day. They have recurrent infections beneath the breast and between the breast. And that itself actually restricts the patient actually for exercise tolerance. They can't run, they can't exercise because of the weight of the breast that they are carrying around. So reduction itself, I don't see it as cosmetic. I see it as non-cosmetic surgery.
That's interesting. What is it classified as officially?
So I try my best to get it as non-cosmetic for insurance purposes, but sometimes it's very difficult. I think we have to change the whole perception that is not a cosmetic surgery.
Yeah, because it's physically and emotionally very painful.
Yeah, and it's something that the patient requires. It actually, their life totally changes.
So with all your procedures, what kind of downtime do you look at with these patients? Because they've obviously got to have major surgery, they're under general anesthetic. What are you looking at in terms of time off work, etc.? So
even in a preoperative setting, before the surgery, we try to plan to get our postoperative bras. And a postoperative bra is one that allows detachment in the middle and detachment on the side, on the shoulders. So when you have to remove it, you don't have to pass it over your shoulder. So it's a lot less painful in terms of removing the bra. I actually put my postoperative bras, be it for augmentation or reductions, on the table while the patient is sleeping. So when they are awake, they have no pain because the postoperative bra gives compression to reduce swelling, as well as it restricts the breast movement, so it reduces pain.
Is this part of the package that you offer patients so that or do you ask them to bring in ones that they prefer?
I think that's the next aspect of the unit that we will try to improve, to actually get the bra, because I actually use a bra called a Marina bra, which I used to use in Toronto. But there are some services from local persons that actually bring bras in. But I think through our department, we will probably look to seek that to get that for our patients as well.
I think that's a great idea. It's a nice initiative.
Yeah.
What about things like pain? How can they recover from pain quickly? Do they need do they get lots of postoperative pain, because you are looking at changing or touching nerves, etc.
Yeah, I'm a strong proponent of managing pain before it begins.
Right.
So if I operate on you, I always tell my patients in a sort of a hilarious way. I would say, I'm actually assaulting you surgically. So I know you're going to have pain. So you have to have painkillers. If you go into an operation knowing that you're not going to have pain, then you won't give the painkillers.
That's true.
So I give my painkillers intraoperatively and postoperatively. So when you wake, there's no pain. And then I give blocks in between. The principle of pain is that it's actually a cycle. When it starts, it gets worse and worse and worse.
Okay.
So you have to break that cycle initially and maintain. So after the pain, the patient has no pain from the first day post-op. Despite not having pain, I still want you to take a multimodal approach of painkillers. So I give like 2 different modalities of painkillers. So you have no pain at all, and within a 3 to 4 days time, you start weaning off that painkiller.
So one of the things that I remember from, it was a while ago now, women that had implants, for example, they wouldn't be able to breastfeed, or it's difficult to breastfeed, or that was the rumor. But I think now things have changed, right?
So the placement of the implant, 1, and 2, the approach to putting the implant. So in the past, we used to do a lot of incisions around the areola.
Right.
So sometimes when you make incisions around the areola, the breast is made up of pipes and ducts, and then the breast is made up of breast components, which is the fibroglandular tissue that produces the milk. So the milk is produced in the breast tissue and is gone within the ducts towards the nipple and drains. Sometimes when you enter around the areola, you can be disruption of those ducts. And if you disrupt those ducts, then obviously the ability to breastfeed may be reduced in certain scenarios. A lot of our incisions now are placed in the inframammary fold and underneath of the breast. So we don't really disrupt those ducts. We don't just disconnect that breast milk forming glands to the ducts to the nipples. So there is still ability to breastfeed.
Stick a pin in this discussion because we're going to go to break. And when we return, we'll be talking about the complications and risks of having breast surgery.
Medical Associates Hospital is the only internationally accredited tertiary healthcare institution in the Caribbean for quality in medical care. Medical Associates gold standard for quality medical treatment, culture of safety for patients and visitors, care based on leading, evidence-based best practices and compliance with international standards make us the leader in private hospital care in the Caribbean. Medical Associates Hospital, #1 healthcare for the entire family.
Hi, my name is Gumti Puhadas, and I am 66 and a half years of age. I have always had, a little pain. Most of the time it will be kidney infection, and it will be treated and pain will subside, and that continued until 2 years ago before I realized what was happening with me. I was advised to do a CT scan, and when that CT scan was done, they found out there was a 3.5 centimeter staghorn stone in my kidney. The pain was so intense I couldn't even walk. I started to vomit and almost lose consciousness, and that is when I was rushed to the medical facility. And I was thinking, okay, maybe they will have to cut, but he started to explain the procedure where it will be just like a keyhole incision. I was so happy for that. When I visit Medical Associates, the staff, they were so helpful and caring, compassionate. They will visit me and make sure that I'm very comfortable in my bed. Whatever is needed, it was done. I am doing everything normally now, no pain. Happy to know that I could do whatever I want. All of my family, whether they eye, ears, nose, throat, whatever, pregnancy or whatever, they visit this hospital. So this is like a family, our family hospital. I feel comfortable here. The doctors, the nurses, the treatment you get here. I am happy that I chose this hospital to do my surgery.
Medical Associates Hospital is the most affordable MRI imaging center in Trinidad and Tobago. Patients have quick access to bookings and service, on-time appointments, high-quality, convenient, and fast scans. With $800 off all MRI scans, we guarantee we have the most affordable MRI service in Trinidad and Tobago. Medical Associates Hospital, #1 healthcare for the entire family.
Welcome back. So we're going to dive into complications of cosmetic breast surgery. Liron, I think there is something called breast implant illness, and it's not something that's often covered, and there's very little that people know about it in general. So let's talk about that.
Yeah. You know, a lot of things in medicine, we would like to have a defined, some sort of clinical test that you can confirm it, but I think it's still a bit vague because it's factors, things like something we call brain fog. You just find that you're exhausted, you have fatigue, you have bone pains, you know, it's just really on joint pains. It's not a clear-cut, definitive diagnosis.
Right.
I think it's mainly a diagnosis of exclusion.
Right.
So you rule up everything else. You don't have another cause for the symptoms. So the only reason could most potentially be the breast implants.
Okay. And what exactly do people feel or experience?
Again, they just feel that extra fatigue. They may get some discomfort, not at the breast side actually.
Really?
But yeah, it's mainly a systemic response to the foreign body.
Okay.
So we believe that it may be that the body has sort of a low-lying, not a significant inflammatory response to give you like cold and fever, what have you, or local redness or inflammation. It gives you a sort of a low-lying systemic illness. So there's not a general clear-cut definition for it. It's a diagnosis of exclusion, really.
So one of the other things that we look at is breast implants and cancer. There's supposedly, or there's myth that there's a causal link.
Yeah. There's one particular cancer. It's not really normal breast cancer we talk about, but it's more of what we call a lymphoma.
Yeah.
So it's breast implant anaplastic large cell lymphoma.
And lymphoma comes from the immune system.
The immune system.
Yeah.
So again, it's really found most times in patients who have what you call a textured implant.
Yeah.
So implants can be smooth or it can be textured, and the micro-texture nature of it, actually the body sees it as something foreign, and the body immune system attacks it, and that can stimulate a cancer. It's like 1 in 30,000 breast implants. So it's very, very rare.
Right.
But, you know, unfortunately, I actually had a case in Trinidad already.
Really?
At Medical Associates, we diagnosed it.
Okay.
She had a surgery in Dubai, and she
Yes, I
had
remember
implants
this lady.
placed, and she presented with a sudden effusion. So that's fluid around the implant. So how does it present? You have a history of textured implants, normally about 5 to 6 years after the surgery. You find for whatever reason the breast feels more full. There's a bit of fluid around the implant itself, and that normally what we do is we aspirate that, send back for testing, and we confirm if there are the lymphatic cancer cells within it.
So with this lady, do you remove the implant and then whatever treatment after that?
So it depends on the stage of any cancer. So we stage to see if it's just confined to the fluid alone, and around the implants there's a capsule, or if it's confined beyond the capsule. If it's confined just to the fluid and the capsule, you can remove the capsule and you can potentially put back on an implant. If it is involving beyond the capsule and surrounding the implant, then sometimes what we have to do is a completion mastectomy.
Right.
This lady, she deemed that she wanted both implants removed and both breasts removed, so we did 2 bilateral mastectomies for her, and she's fine. She was cured basically from
Good.
it.
That's nice to hear.
But that's not all implants. I don't want to create a sense of fear for implants. That's just a textured implant, and it's very rare. And we know that we have to monitor those type of implants. And sometimes we remove those type of textured implants and put in smooth implants, which has definitely a lower risk or no risk at all for BICA, which is the breast implant cancer.
So we've touched on breast reduction today, but we didn't talk about what the complications are or the risks of having breast reduction.
So as a surgeon, you must always know what are complications and risks that could happen. So again, if you could know what these complications are, you can mitigate them, you can reduce the impacts of them. And also patients need to know, because after an operation, the patient will come and say, but doc, I didn't know this before. So one of the main things is there is a bit of reduction in sensation to the nipple, because obviously you're moving around breast tissue, you're cutting skin, nerves come from skin, comes from within the breast tissue, so there may be an element of reduction in sensitivity to the nipple. Also, your ability to breastfeed may be reduced. And I say may be reduced because we keep the nipple on some breast tissue, but the volume is obviously less. So the required quantity of breast milk that you may need may be diminished. So there is still ability to breastfeed. So I would normally quote like about 50 to 60% of patients can still breastfeed, and 40 may not get enough sufficient breast milk.
And you counsel them of this risk before they have this surgery,
Definitely.
right?
Yeah, and again, with breast reductions too as well, it depends on, a lot of women come, doc, I want the incision around the nipple. It really is dependent on the level at which we have to move the nipple and the size of the breast. Not all women can have that incision. Generally, most of the patient that comes has significant amount of breast tissue and significant amount of downward drift to the breast. So they need that anchor incision. So there's significant scars that you could have as well.
Now, infections. I think that's the most commonly seen complication of breast implants.
So when I do these operations, my assistants and they know I'm very, very particular. There are certain things about preventing infection. One, you have that preoperative, obviously, ensure that there's no local infection to the skin where you're going to operate. And then intraoperatively, you ensure that certain techniques abide. I touch the implants by myself. I use special tools to put the implants in. Use antibiotics interop. All the instruments that I use for the reconstruction is soaked in iodine. So it's very, very sterile technique to ensure that the implants is infected. And then afterwards, we give antibiotics and make sure that the wounds don't get irritated or infected.
How often, generally, out of normal statistics around the world, does the infection rate look at with?
So in a reconstructive element, it can be greater. It can be somewhere like probably in the teens, like 15%. In an implant base, it's probably like about 4 to 5%. But the risk is there. But we know any problem that arises, if you are ignorant to it, you don't know how to prevent it. The fact that we know that it may happen, we are very cautious about trying to prevent it from happening. But I don't want patients to feel that it cannot happen. There is still a risk.
And there's also the risk along the actual scar tissue itself to develop infection.
Definitely.
And what do you do to mitigate those risks?
Good, clean, sterile dressing and good closure of the wound. So I use about 2 layers of closure. I use steri strips and we use waterproof dressings to prevent any sort of bacteria from getting in.
And what else would you recommend for patients in terms of looking after their implants post-operatively? So
post-operatively, again, I will normally have put in a post-op bra. And that will give support to the breast itself and actually give compression to reduce swelling. No heavy lifting for about 10 to 15 days. No heavy lifting.
Just 10 to 15
no heavy
days?
lifting in terms of nothing more than 5 to 10 pounds. And then beyond that, within a 4 to 6 weeks period, no lifting of any exercise like gym, pectoral, chest muscle exercises. Within 3 to 4 weeks' time, you can start doing a normal cardio, walking, what have you. But again, that's providing that the wound has closed and it's nice and healed, because I don't want any bacteria to get in through the wound.
Sweating and things like that.
Definitely in our environment, sweating is there. But no heavy lifting for at least 10 to 12 days afterwards, which is more than 5 to 10 pounds. And then after, you can go ahead and start doing the exercise about 4 to 6 weeks afterwards.
So I'm going to touch on something controversial, perhaps. Men that have breast tissue and managing that for them.
So men can have breast tissue, what we call that is gynecomastia.
So that's enlargement of their breast tissue. Men actually have breast tissue. Sometimes it can be an element of fatty tissue with breast tissue. You have like 3 times in a lifetime a man can get gynecomastia. When you now come out from your mom, you have that high estrogen level, so you can create a breast bud. And then as it making that conversion from a teenager, you can actually get an increase in test levels, and the estrogen levels can cause sometimes a bit of bud to create in the breast, gynecomastia. And then coming down later in the age, patients who have liver disease, patients who have kidney disease, patients who drink alcohol a lot, what that does is actually reduce the ability to break down the estrogen in the body, and it builds up and you get gynecomastia. So yes, definitely there's surgery for it. I mean, we always have to rule out first that is not an underlying malignancy. So men actually have mammograms in that scenario to make sure the lesion is gynecomastia and not a tumor. And then we can do various surgeries depending on the levels of gynecomastia. So you have different types. Again, same principle where the nipple is, how much volume. We can actually do incisions around the nipple to remove the breast tissue, or we could even do reduction techniques.
There are some REMS and options for patients like that as well.
Well, that's really interesting. And have you had any patients recently or in your lifetime with male patients I'm talking about that have had surgery?
For gynecomastia?
Yeah.
It's a common thing. It's a common surgery as well, where we can do reduction techniques, or even what we could do like a double incision around the areola and actually reduce that breast volume for them.
Nice. So this has been very interesting, and I hope that everybody that's been listening has also found it interesting. Thank you very much for coming back to talk with us.
Thanks again.
We are very, very glad to have you, and we're so grateful that you continue to watch our episodes. And feel free to catch us if you've missed this one on our social media pages, including Facebook, Instagram, YouTube, and Spotify. So until next time, take care.